Hello, Assalamualaikum. I'm Miss Coordinator Samara Auto, and I'm here to present you the topic of intestinal obstruction. So let's start with the learning objectives. We have at the end of session, the students will be able to describe the various types of intestinal obstruction, to enlist the causes of intestinal obstruction in adults and children, to enlist the causes of pseudo obstruction, to manage the patient of intestinal obstruction. So what is intestinal obstruction is? As the name suggests, it is the interruption in the normal flow or propulsion of intestinal contents along the intestinal tract. So we have a different types of classification of intestinal obstruction. We can classify the intestinal obstruction according to the pathology, according to the anatomy, the nature of presentation, and the pathological changes in the bowels. So according to the pathology, it is divided into the adynamic or the adynamic obstruction. The dynamic obstruction is where the peristalsis is working against a mechanical obstruction. We also called as a mechanical obstruction. Adynamic is where there is absence of the peristalsis without any mechanical obvious obstruction in the lumen, like in absent peristalsis in paralytic ileus, or the non-propulsive form which occurs in the mesenteric vascular occlusion and pseudo-obstruction. Then according to the anatomy, it is classified into the small bowel obstruction or the large bowel obstruction. Then according to the nature of presentation, it can be acute and chronic, or the subacute obstruction. Then according to the pathological changes, it can be simple obstruction, where there is obstruction but the blood supply is intact, while in the strangulated, where there is a direct interference to the blood supply, the blood supply get obstructed, or we can say it is interfered, and it can lead to the gangrenous or necrotic of bowel wall. Now the causes of obstruction. We will divide the causes into the mechanical and the functional causes. The mechanical causes, which is the dynamic obstruction causes, includes the extramural, intramural, and the intraluminal obstruction. Extramural are those which is outside the bowel wall or the lumen. Intramural is within the wall of the bowel, and intraluminal is inside the lumen. Then the functional obstruction, which is caused by paralytic ileus. The functional obstruction is also known as the adynamic obstruction, and the causes for this are the paralytic ileus, which can be due to post-operatively inflammatory causes, metabolic causes, and the neurogenic causes. So here we discuss the causes in details. The extramural causes are adhesions, which is the commonest one in the patient having the history of previous surgeries. Then the hernia, we call it the obstructed hernia. Then volvulus. Volvulus is actually the rotation of the gut around its mesentery. It twisted around its own mesentery and leads to the obstruction. Then the neoplasm. Neoplasm are usually those which are extramural, means they are not the part of the gut. They are some other neoplasm which causing the pressure effects over the gut. Then the intramural causes, it includes the neoplasm of the gut itself, including the colorectal or any gut tumor. Then we have the strictures. Strictures are the narrowing of the portion of the bowel wall. Then intussusception. Intussusception is the invagination of one portion of the bowel into another one. It can be ileoileal or ileocolic, and usually it occurs in children. Then intraluminal causes within the gut itself, in the lumen. And gallstones. When the gallstones get entered into the bowel, like due to the fistulation between the gallbladder wall and the duodenum, it leads to the fistula formation, and the gallstone, usually a single stone which passes from the gallbladder to the small bowel, and it can lead to the obstruction. Then we have the fecal impaction. It could be in the lower rectum. And bezoars. Bezoars are actually the compact ball, which is usually formed by the undigested or the digested material. It usually fibers or the hairs. Then we have foreign bodies. Other is the intramural hematoma, which is within the wall and it projects into the lumen. This is a picture of the gut intraoperatively. It's showing the dilated portion of the gut, and there is a narrowing segment here, and the gut proximal to the obstruction is dilated. Then this is another picture taken intraoperatively, which showing a structure which is marked by an arrow, and it is the structure portion, and you can see the marked difference between the proximal and distal portion of the bowel. The one is the proximal, the one which is proximal is dilated, and distal to the structure is collapsed. Then we have a normal bowel and intussusception. You can see the normal bowel wall. When it get intussuscepted, like portion of the small gut is invaginating inside the other portion. This is a picture showing the volvulus, and this is a sigmoid volvulus. The volvulus is actually the twisting of the gut around its mesentery. Usually occurs in the adult. So now there is a different causes, which some are common in the elderly, some in the adults, and some in the pediatrics population, like carcinomas and diverticulitis, sigmoid volvulus. These are common in the elderly and leads to the intestinal obstruction, while in adults the hernia and post-operative adhesions are the commonest one. Then in pediatrics we have intussusception, congenital hypertrophic pyloric stenosis, atresia. Atresia can be of the duodenum or the ileum. Then meconium obstruction and volvulus neonatorum. The same volvulus we have discussed before, but if it occurs in the neonates, then we call it the volvulus neonatorum. Then adynamic obstruction. The causes for the adynamic obstruction are either vascular occlusion, which can lead to ileus. Then we have a spastic ileus. In this, the intestine remains contracted and no propulsion occurs, and it occurs usually in the systemic causes like uremia, porphyria, or heavy metal poison. Then adynamic ileus, it occurs post-operatively, mostly after the abdominal surgery. Sometimes the gut remains in the ileus. Then we have the more metabolic causes like DKA, which is a diabetic ketoacidosis, hyponatremia, hypokalemia, and hypomagnesemia. Certain drugs like morphine, TCAs, and antacids and anticonvulsants. Then intra-abdominal inflammation like sepsis or cold wound infection. These all leads to ileus. Then pneumonia, renal stone, retroperitoneal hematoma, fracture spine and raves. These are the other causes of adynamic obstruction. Now the clinical features. The commonest presentation of the intestinal obstruction are the vomiting, colicky abdominal pain, abdominal distension, and absolute constipation. Absolute constipation is also known as the obstipation, in which there is a complete constipation in which the patient is unable to pass the stool or the flatus. These are known as the cardinal signs of intestinal obstruction. When you're going for the examination of the patient with intestinal obstruction, you have to look for the visible scar, which shows the cause as a band or adhesions. Then on palpation, you will see the hernial orifices. Then you will see is there any mass palpable there on palpation, which shows that there is, if the mass is slightly tender, large, it shows there is some torsion, intussusception. And if the mass changes its position with the colicky pain, it could be a mass of the ascaris worms, worm infestation. And then a tender indurated mass which showing intraperitoneal abscess, while impacted hard masses can be a fecoloma. On percussion, you will have a tympanic sound because the proximal bowel, which is dilated, is usually contains the air, and air gives you a tympanic percussion note. Then on auscultation you will see a high pitched sounds of the gut because of some mechanical obstruction, or either you have an absent bowel sound which shows the ileus. Then the rectal examination, you have to do a rectal examination as a part of the abdominal examination in patient with the intestinal obstruction, because sometimes it shows the you will see on the finger it is stained with the blood or the mucus, and it's showing some lesion inside, like some malignancy, or you can find some hard mass of feces, or any mass in the rectovesical pouch can be felt on rectal examination. Then investigations. How will you investigate a patient of intestinal obstruction? You will start from the blood test. It includes the CBC, serum electrolytes levels. CBC can indicate some anemia, like the patient of malignancy, means older age group patient having intestinal obstruction and having anemia is suspicious of some malignant lesion. Then serum electrolytes, which shows some electrolyte imbalances which can lead to paralytic ileus as well. So in radiology, you will go for the plain X-ray abdomen. This is the first investigation you will advise in the patient with the symptoms of acute abdomen, the plain X-ray abdomen, erect and the supine. In the erect X-ray, you will find the multiple air fluid levels, and in the supine X-ray, you will see the dilated bowel loops. Then there are some features like valvulic connivente and the hostrations in the X-ray. We will discuss in the later slides. This is the abdominal X-rays. The one is the erect, which shows the multiple air fluid levels. You can see this is the levels lines. These are horizontal lines, which is the air fluid levels, which shows the obstruction, intestinal obstruction. And then in the other X-ray, which is taken in the supine view, there is this black shadowing and whitish line of the gut wall. This is the dilated bowel loops. This is the X-ray which shows the small and the large bowel obstruction. The one in the small bowel obstruction, the maximum diameter is 3 cm, and in large bowel obstruction you can see the diameter of more than 6 cm. Then in a small bowel obstruction you can see the valvulic conniventes, which are the lines which shows the dilated portion of the jejunum, and they are the cross all the way across the bowel. While in the large bowel obstruction you can see the lines are not fully crossing the bowel wall, and these are known as the hostration. Ileum is usually characterless on the X-rays. Then in a small bowel obstruction you can see the obstruction or the bowel loops within the central part of the X-rays. In the large bowel obstruction you can see in the peripheral side. Now investigation. Other investigation includes the chest X-ray. In X-ray chest you can see the gas under diaphragm on the right side. Usually you can find a gas shadow on the left side of the diaphragm, which is the normal one, but when you see the gas under the right dome of the diaphragm on the X-ray, it shows that there is some bowel perforation. Then elevated diaphragm, it can be due to some mass or obstruction. On ultrasound you can find a free fluid, which is because of the complication of the intestinal obstruction. You can see some masses on the ultrasound. You can see mechanical obstruction or paralytic ileus, means on ultrasound you can see whether the gut ball is moving or not, peristalsis is there or not. Then on CT scan you are able to find out the level of obstruction. Then cause of obstruction, means either there is a mass within the lumen, outside the lumen, you can see it on the CT scan. And also the complication, whether there is a perforation, there is any other abscess, or there is any other collection, you can see it on the CT scan. Then treatment. All the patient with the obstruction, intestinal obstruction, you have to start with the conservative management first, and then we'll plan for the surgical treatment. In conservative treatment you have to keep the patient nil per orally. You have to keep the patient NPO. You have to advise not to take anything orally, because there is already obstruction, and if you take it orally it will aggravate the condition. Then pass a nasogastric tube which is called as angi-decompression, to remove all the secretion above the obstructed segment and to decompress the bowel. Then for the pain we will give the analgesics, antibiotics, because whenever there is an obstruction there is a chances that it can leads to infection. Then we have fluid and electrolytes management, because it can lead to the third spacing, loss of the fluid, and the patient is NPO, so you have to manage the fluid through IV lines. Now the surgical treatment. The indication for the early surgical intervention are usually the obstructed external hernia, clinical features suspicious of the intestinal strangulation. If you think then there is some compromise with the blood supply of the bowel, then better to go for the early surgical intervention, because it can lead to gangrene of that segment, which is compromised blood supply and the bowel necrosis. Then obstruction in the virgin abdomen is also an indication for the early surgical intervention, because when there is some history of previous surgery, we will think of the adhesions as a cause of the obstruction, which are usually relieved on conservative treatment. But in the virgin abdomen there is some mechanical cause, so better to go for the early surgical intervention. The surgical treatment are usually we go for the exploratory laparotomy, and we will do the surgical treatment according to the cause. If you found a volvulus, we can derotate it and go for the surgical intervention. If there is a gangrenous portion of the segment of the bowel, we have to resect it. If there is a band adhesions, we have to remove that surgically. So the surgical treatment depends upon the cause, which you can find on the exploratory laparotomy. Then we have the complications if not operated. It can lead to strangulation. Strangulation means the blood supply is compromised and the bowel leads to gangrenous of that portion. Then perforation, the proximal segment which is already dilated, it can lead to the perforation. Then electrolyte imbalance and dehydration. The conclusion is that the classical clinical advice is the sun should not both rise and set on a case of unrelieved acute intestinal obstruction. Means you have to decide within a day whether you have to go for the surgery or the conservative treatment. If there is no evidence of ischemia, postpone surgery till resuscitation is enough. Whenever there is obstruction is due to adhesions, then conservative management may be continued for up to 72 hours in the hope of a spontaneous resolution. Thank you.